conference land. I miss seeing everybody. I miss interacting with my colleagues, and we're doing the best we can. COVID has been a crazy situation for all of us ID doctors. We're giving virtual conferences right now, and unfortunately, a lot of our stewardship initiatives have been on the back burner. But today, I'm excited to talk to you about non-academic antimicrobial stewardship. And so I want to thank the folks at IDSA, at SHEA, and the Committee with ID Week for letting us share our experiences. And I have the fortune of having one of my pharmacists that I work with, Drew Zimmer. He's gonna bring it home at the end with some of his experiences, and we'll get through this. We'll get through this pandemic together. So over this talk, we're going to discuss some of our experiences with antimicrobial stewardship in the not-for-profit hospital setting. We're going to talk about the regulatory and business aspects of this, how to embed your program into a medical staff, and then we're fortunate to have one of my stellar ID pharmacists that I work with, and Drew will be talking about some of his experiences across the continuum of different healthcare settings. So a little background on our practice. I'm an employed physician. There are 3 doctors and a PA, and we cover a little over 700 acute care beds, in addition to some long-term care and rehab beds. And then we have 4 hospitals, about 550 beds for the main hospital. And the way an arrangement might look in the non-academic world for an employed physician specifically, might be about a third to a half maybe, or some fraction of your compensation might be routed through a medical directorship. In my case, it's through a medical directorship of infectious disease, which entails hospital epi, infection prevention, and stewardship. So as you approach a healthcare system or you approach your employer, it's important to understand how many ID docs are already practicing there, and are these from different groups. It can get tricky when you're doing stewardship and you have multiple different infectious disease practices in that hospital. It really matters how you set up these agreements, whether you're employed, and then it also who does the infection prevention in your system, because you're going to be working intimately with those folks. So a couple of the things unique to what we do in maybe community hospitals are, I think one of the keys is to really have an open dialogue with the pharmacy, as opposed to an academic center where maybe you have faculty who have primary responsibility in stewardship, or maybe parsed out time for stewardship. You're working with the pharmacy staff and the nursing staff on a day-to-day basis. So it's really embedded in your clinical practice. Stewardship is really inseparable from my patient care activities. And some of the other things are on this slide. You can look at some of the pathways and order sets. We are really linked to those and primarily responsible for treatment protocols and pathways that involve anti-infectives. And I really think scheduling your meeting times with your stewardship program is super important. If it's not hardwired on your calendar, it falls off on the back burner. So why we have stewardship outside of academia is really an easy question. The evidence is compelling. We know it works, and we know it's required by Medicare. We know that condition of participation is a big word. Your administration wants to make sure that we comply with those CMS regs. So you're going to have a program in your long-term care facilities. I can tell you for sure that the accreditation organizations like Joint Commission, they're always going to ask about your quality initiatives. What are you doing in the outpatient world for stewardship? And so you can really check those boxes with a good, robust program that's integrated into your healthcare system. And then the other thing that I really think we've been good about is being opportunistic with stewardship. So we have really smart people on our program. Our pharmacists have decentralized a lot of stewardship to where they teach the floor pharmacists how to best dose vancomycin or extended use antibiotics, how to manage antiretrovirals on the floor, when to hold them, when it's okay to stop, things like that. So sort of decentralizing your stewardship, but being opportunistic for opportunities to really show your value in the healthcare system. And I think about remdesivir right now. That's almost a full-time job. We have 95 patients in the hospital with 550 beds. And so you can imagine stewardship over remdesivir is a very busy job, and that's just something they've had to add on to their to-do list. Jumping into our clinical trials and being a key cog in the pharmacy part of some of our drug studies, educational modules for the medical staff, even CME programs. And then what I think is key is in the community hospital, you really want to be an invaluable asset and the go-to expert for all things antibiotics. We actually have surgeons that will just directly go to our pharmacists for antibiotic recommendations often. So it's great to have a program where that point person is embedded in your stewardship program and they're the go-to expert. And a little more on the why stewardship. I mean, I think we've all seen these slides talking about 20 to 30% of antibiotics, both inpatient, outpatient, are either inappropriate or inappropriately dosed, unnecessary. And so these are really the backbone of why stewardship is key. And being that I've worked a lot on ID compensation and the value of ID, I'm asked this question a lot. How do we staff a program? So are there data on how many FTE doctors for a stewardship program of X amount of size? We cover this many beds. How many doctors would we need? So I know there's some international data on some of the other countries and provinces where stewardship's required, and the government may mandate a certain number of doctors or pharmacists allocated per beds. But really the IDSA, we've tried to get away a little bit from thinking about it that way and think of it more as an administrative job, more of an executive function, where you actually are overseeing an arm of the hospital, working more at a executive function, the point person for these initiatives, where you have a salary with incentives. Maybe it's some sort of P4P for the doctor running the stewardship program. Now, they can't directly compensate a doctor based on antibiotic spend, so they can't say, we'll pay you this much if you cut our costs. But you can definitely link your performance, your P4P, to things like stopping vancomycin in ICU patients where we know it's nephrotoxic, or reducing unnecessary double gram-negative or double anaerobic. So you follow those metrics over time, and then you put interventions in place, and then you remeasure. And a lot of times those can be part of the compensation plan for an ID doctor doing stewardship. But when the rubber hits the road, people want to know, if you have X amount of beds, about how many ID docs do you need. And so this is a number that I've used over time. And so 120 beds, you need about 0.1 ID doctors. So if you had 500 beds, you'd probably need about 0.4 to a half FTE just to do stewardship. And so those are the kind of references you can take to administration. You know, keeping in mind in the community hospital world, you don't have fellows to rely on and carry the pager, so you're doing all this work yourself. But as a general rule, 120 beds, 0.1 FTE is probably a good starting point. So one of the things that I really always try to keep in mind as you talk about building a program or sustaining a program is, if you already have it, is it something where you're looking at, have you lost money or made money in your healthcare system on some of these P4P metrics? For instance, NHSN measures and your Medicare reimbursement, QHIP from Anthem Blue Cross. A lot of these payers have P4P metrics that are tied to things like stewardship and infection prevention. So as you approach a hospital or as you're trying to do stewardship in the community, you really want to know how your hospital is performing on some of these metrics. It's things like automatic ID consults, management of multi-drug resistant organisms. Are these already in place? How's your system doing on the P4P metrics? And then you try to think about bundling all those up into a plan.
I don't want to talk to them. Just put that.
And so my experience and a lot of the guidance that I give to docs if they're trying to start a program or looking how to sustain and determine your FTE, your compensation. First, again, like I said, look at your P4P metrics, the things that you can affect. We know that good hospital epi and stewardship over surgical antibiotic prophylaxis, you can impact things like SSIs, and you can definitely impact your standard antibiotic ratios through stewardship. And so know if these have fallen out in the past. And then you go to the literature, and I'll show you the link to the IDSA's website, and you say, where is there evidence-based practices where ID doctors can intervene on these interventions and show improvement? And then you go back to what the original metrics were. You look at these evidence-based interventions, and you try to show these cost savings. You try to show improvement in things like P4P, create models where you can show we can impact a standard infection ratio for NHSN by doing this or that based on the literature. And so those are really valuable experiences that you can bring to the table for an administration. And those are actually the metrics that our feet are held to the fire every year, because we try to make goals, and we try to hit those goals. So we're accountable to all those metrics every year. And then a couple other little tips from my experience in the community hospital is, we're using new metrics to follow antibiotic utilization, but it doesn't mean the old ones are outdated. So I like to look at antibiotic utilization across the system from multiple different lenses, maybe days of therapy, maybe you're looking at that antibiotic utilization in your SAR numbers from NHSN. But I think that a key component is to have all of these people at the table. The quality people, the safety people, the surgery division, they don't really care about your SAR, and they don't really care about your days of therapy. They want to see outcomes. They want to see less C. diff and fewer MDROs. So there are multiple different lenses that you have the luxury in a community hospital. You're not siloed so much. So you're looking at this whole phenomenon from an executive higher level, and it gives you a lot of latitude. And I really lean on our learners for our quality projects. So anytime we have an initiative, I look to nursing students, nursing graduate students, our pharmacy residents, and medical staff. We have the luxury of having medical students and residents. And so a lot of these initiatives, we roll over into scholarly activities for our learners.
And he's not giving it up.
That's okay.
And then I do think it's key that as you run a community stewardship program, you're going to be the one responsible for the literature. So I try my best to be up to speed, but there are just a few things that you have to know. I mean, we have to command the literature on interventions where ID-led stewardship shows improvement in outcomes. And I just put a couple of those references here. But this is the key slide that I really want people to bookmark. This is the IDSA's website, and it contains a lot of the links to these folders where we have compiled resources for doctors out in the community. And we have everything from articles on compensation to how to show your value, how to deliver the message, and articles on how to build these contracts for reimbursement. So this website is really a key cog in how a community physician should approach starting up, monetizing a program, sustaining it, showing value, all of those kind of non-patient care activities. And this is a great resource for the community docs. And then I have the privilege and luxury of having my colleague, Drew Zimmer, who's an ID pharmacist who works with me. And so I'm going to let him talk a little bit about his daily life and our stewardship experience.
Thank you, Dr. Troutman, and thank you to the IDSA, Shay, and the committee of ID Week for letting us share some of our experiences in our antimicrobial stewardship program. My personal experiences, I've seen pretty much every antimicrobial stewardship program that there is out there. I have practiced in a large academic center with an ID program with ID fellows, a training program. I've been in a small community teaching hospital with no ID physician on staff, very little ID backup for our antimicrobial stewardship program. And currently I'm in a large community hospital with dedicated ID physicians and staff to our program. Currently, from a pharmacy standpoint, I'm one of two full-time PharmDs dedicated to the antimicrobial stewardship program for our main hospital and then three smaller community hospitals in our system. We have a centralized stewardship program with a main antimicrobial stewardship committee who also gives us participation from the outlying hospitals in the form of physicians. So the things we do at our hospital, my colleague pharmacist and I both monitor all positive blood cultures. We have, through our antimicrobial stewardship committee, a policy of automatic ID consults on all positive Staph aureus and yeast in blood cultures. Enterococcus is not an automatic consult, but with our ID service and how intertwined the pharmacy and RD physicians are, they are most often times involved in any enterococcal bacteremia. Other bacteremias caused by other bacteria, both the other ID pharmacist and I will evaluate them. If we see that an ID consult is needed, or just to get some recommendations, we'll side consult with our ID physicians, and if they deem it necessary, we'll do an official ID consult. We also look at coag-negative staph and other bacteria that are considered contaminants, and the other ID physician, pharmacist, and myself will look at those and kind of evaluate them so that even most of the time they are contaminants. We look at things that may need a little more dedicated look at those bacteremias. We have weekly antimicrobial stewardship rounds in the medical ICU. This is a major learning experience for one of our pharmacy residents who staffs up there. One of our ID physicians will join us weekly. We'll go through patients. They will offer recommendations, run by any type of recommendations to the ID physician, who also provides education for them. So it's a very nice learning experience for the pharmacy residency. We also practice antimicrobial stewardship at some of our smaller hospitals. At one of our larger, smaller community hospitals, both the other ID pharmacist and myself will be down there one day a week for an on-site participation where we evaluate again positive blood cultures, more multi-drug resistant bacteria that may need a little more guidance from an ID physician. We also have pharmacist and nursing education using the Society of Infectious Disease Pharmacists website. They have an excellent podcast, which is known as Breakpoints Podcast. It's available on all of the podcast venues. They also provide a 5 ways to be antibiotic aware, which is a nice way to educate non-ID pharmacists on ways that they can help with antimicrobial stewardship. So for institutions that are in a non-academic setting, if you're wanting to build or strengthen your own antimicrobial stewardship programs, here's just a few recommendations and low-hanging fruit for you to go after. First is overuse of vancomycin and anti-pseudomonal beta-lactams. We know that the use of vancomycin and piptazo can increase renal dysfunction and adverse drug reactions. You should be embedded in all C. difficile infection prevention measures. It should be one of your top priorities for your antimicrobial stewardship program. And using short-course antimicrobial therapy, that's an easy low-hanging fruit to shorten and decrease the amount of antibiotics used in your institution. You should involve and educate all pharmacists to be antibiotics aware, and very important, involve nursing. This is a practitioner that is with the patient daily and someone that we could really utilize in antimicrobial stewardship. For institutions that either don't have an ID physician on staff or are running a non-ID led stewardship program, consider some sort of antimicrobial stewardship or tele-ID. And then work hand in hand with your micro and infection prevention departments to widen the scope of your antimicrobial stewardship initiatives.
So we'll wrap this up. I want to thank the folks at IDSA and SHEA and from the ID Week committee. I left Drew and my email here, and I hope that people will reach out, maybe share experiences, ask questions, and hope everybody has a great virtual conference.